So good evening and welcome to all the session today's evening on the NOEL. The fourth edition of NOEL, we managed to conduct across the countries all the students trainees of NNF. We conducted 3 years consecutive this training session throughout the year. This year we started this month in February. We're planning to run this session till October, till before the exam. So fourth edition of this session, today third session. This third session, first session of the respiratory module, we conducted the NRP neonatal resuscitation, all the advances beyond 2020. 2020, as we are aware, the consensus statement came ILCA recommendation, but beyond 2020 till 2024, the advances we discussed. The next session, we discussed a ventilation, how to initiate, when we needed mechanical ventilation, how to initiate. And this is the third session. And one of the key components of respiratory therapy, as we are aware, we are more and more today, we are favoring more CPAP, more NIV. And today's session will be more practical based and more useful for all the learners and all the people already who ventilated the babies for years together. Now they're more likely to do the CPAP. So one of the key sessions today, I welcome all the presenters today. So today to run the session, here Dr. Mehak Munjal. She is the NNF fellow from Dayanand Medical College and Hospital, Ludhiana. She is a neonatal fellow from the NNF training. She will go with the presentation of bedside case presentation on CPAP. To guide her, Dr. Kamaldeep Arora, who is professor of neonatology from Dayanand Medical College and Hospital, with a keen interest for teaching academics, and he is a well-known resource person for all the workshops and CMEs across the country, with a special interest in mechanical ventilation and respiratory care of newborns. He is there to guide throughout the session. Today he's moderator of Dr. Mehak. So we'll see the first 30 minutes presentation from the team of Dayanand Medical College and Hospital. In the second half, we will listen from Dr. Monica Bairagi. She will present, NNF fellow from BLK, Max Super Specialty Hospital. NNF fellow, she will present next 30 minutes about the bedside application and nuisances of CPAP. The nut and bolts of CPAP will learn from her presentation. And to guide her, Dr. Kumar Ankur, who is the director and HOD of Department of Neonatology, BLK Max Super Specialty Hospital, and is a young organizer of the NNF Delhi, young dynamic faculty and known across the country. And he will be there throughout the session to discuss about the NNF, this session, NOEL session, CPAP session. And both the session to supplement and to enrich us. Dr. Rajendra Prasad, who is today's expert faculty. He is Associate Professor of Manipal Medical College. With after DM from AIMS, he is faculty in many of the places. He worked in Hyderabad in Fernandez Hospital, AIMS Hyderabad. Then he is faculty in Manipal Medical College and Hospital. With his experience in the intensive care for the newborn, he will probably today's lead faculty for the session. And I will invite now to continue the session. With this, I'm handing over to Dr. Mehak to start the session, and next 30 minutes yours to go through the CPAP session. Thank you all.
Good evening to all.
Please, all the faculties and moderator, if you want to say some words before the session, please, you can pass some message and we can go through the session.
Good evening to all the students. I am Dr. Kamal from Dayanand Medical College and Hospital, Ludhiana. My request to all is that please participate in the discussion part. We will be happy to give your answers in the chat session. And because this is more of a practical session, we are in the nursery just because we want to teach you that practical part. If you have any issue like humidification, how to put the nasal bubble CPAP, what are the complications, anything which is there in your mind, please don't hesitate to ask us. Fine, that is the only request. Please participate actively in this session. Thank you. Okay, over to Mehak to start with.
Yeah, we can start, sir. We will keep it more practical as you are all telling. We will avoid going into the theory. Like we will be more like hands-on. What has to be done on the bedside, how to identify the errors and problems, and how to rectify them. We'll focus on them in this session.
Next up.
Can I share my slides, sir?
Yes, please.
Yeah, please go ahead.
A very good evening to all of you. My name is Dr. Mehak Munjal, and today I'll be presenting a case of neonate on CPAP support under the guidance of my mentor, Dr. Kamal Arora. I'm presenting the case of a single male baby born at 28 plus 1 weeks of gestation with a birth weight of 1160 grams, who was born by vaginal delivery. And currently the baby is at day of life 16 with a post-menstrual age of 30 plus 3 weeks. The antenatal history. The baby was born to a 35-year-old mother who was Gravida 3, Para 1, Live 1, A1 mother, and was a product of spontaneous conception. The mother has a 3-year-old male baby who was born at term normal vaginal delivery. Also, she had a spontaneous bleeding abortion at 6 to 8 weeks. She was booked at our hospital DMC at 6 weeks of gestation as she was UPT positive at home and took periconceptional folic acid. In the first trimester history, there was no history of any teratogenic drug exposure, any radiation exposure, fever, rash, or bleeding per vaginum. Her first ultrasound was done at 6 weeks to confirm the pregnancy, wherein the cardiac activity was present, as the mother told us, and the level 1 scan was normal. Second and the third trimester history, calcium and iron supplementation was taken properly, and she had 2 doses of Tdap 4 weeks apart. There's no history of any gestational hypertension, diabetes, mellitus. There's no history of gestational hypertension or gestational diabetes. No history of bleeding per vaginum or leaking per vaginum. No history of decreased fetal movements, excess or decreased amniotic fluid. She underwent level 2 ultrasound at 18 weeks of gestation, which according to the mother was reported as normal. And also her blood group is A positive. In the medical and the surgical history was insignificant, and she's not on any chronic medications. She presented to the hospital at 27 plus 5 weeks of gestation with pain abdomen. She was initially evaluated and found to have a urinary tract infection by the gynae team, as her urine routine showed 69 pus cells and the urine culture was positive for E. coli with a significant colony count of 10 raised to power 5 per colony forming units. When she was administered 1 dose of antenatal steroids, just 12 hours after that, she delivered the baby. Therefore, she had an incomplete steroid cover.
Dr. Mehak,
She perinatal.
Dr.
Yes,
Mehak, you told that it was only 1 dose of antenatal steroid was given.
Yes,
Go back
sir.
to the slide. Go back to the previous slide. Yeah, 1 dose of antenatal steroid was given. No, next one. So what was the anti-steroid given in your unit? What is that protocol?
In our unit, according to our unit policy and elsewhere, is also dexamethasone is the drug of choice as the antenatal steroids, and here also we gave dexamethasone. The usual dose is 6 mg, 12 hourly, and 4 total doses are given. So the total dose is 24 mg for dexamethasone.
For this patient, only 1 dose was given.
Just 1 dose, sir. Just 6 mg, one dose was given, but the patient delivered after 12 hours.
Okay. And what is the most common cause of the preterm delivery? Like the mother had 27 weeks and she was having the pain abdomen. What is the most common cause of any preterm delivery?
Sorry, sir. Sorry, I couldn't hear you. Sorry.
What is the most common cause of a preterm delivery at this station? Like 27.5 weeks, mother comes to with pain abdomen and you evaluated for something. So what is the most common cause of any preterm delivery which happens? So I
usually,
yeah,
usually
right.
Yes, sir. Maternal factors are the causative agent between that lead to a preterm delivery. For example, in this case also, since the mother having...
It is subclinical infection which is there in the mother, which leads to this the preterm delivery and the rupture of membrane. So in this case, you had a UTI, which is the most common cause. Most common cause is sepsis, subclinical sepsis. Right. Next,
yes,
carry
sir.
on.
Yes, sir. So she had a history of preterm premature rupture of membranes for 24 hours and spontaneously delivered prior to the delivery and had spontaneous onset of labor. The amniotic fluid was clear and the fetal well-being was monitored by CTG and intermittent fetal heart auscultation. The baby was delivered by vaginal delivery and had a vertex presentation. This baby required resuscitation in the form of only initial steps, that is warm, dry, stimulated, and positioning of the airway, suction required, and was assigned an ABGAR score of 8 and 9 at 1 and 5 minutes respectively. Now, the perinatal history being continued in view of nasal flaring, sorry for the extra line, nasal flaring, grunting.
Sorry,
and
one question. What about the cord clamping? Was it early or delayed?
In this baby, we carried out early cord clamping.
Okay. Okay, fine. Continue.
Yes, sir. In view of nasal flaring, grunting, and subcostal and intercostal retractions, baby was put on a T-piece resuscitator to attain the sustained lung inflation with a PIP of 15, and a PEEP of 5. Since we don't have a CPAP within the labor room, therefore we put the baby on a T-piece resuscitator and transfer to NICU in an incubator. Now the postnatal care in NICU. In NICU, the baby was put on Fisher-Paykel nasal bubble CPAP, and the initial settings were a PEEP of 6 centimeter water, FiO2 40%, and flows of 3.5 liters per minute. The Silverman-Anderson score of the patient of the baby when received in the NICU was 6. Baby was administered 1 dose of surfactant by in-shore technique. Neosurf was administered at 5 ml per kg. So this was an early rescue as the baby was given surfactant within the first 2 hours of life. No antibiotics were started as there were only 2 identified risk factors for early onset sepsis. That is, the baby was premature, low birth weight, and there was significant leaking per vagina of more than 18 hours. So no antibiotics were started empirically. And also, baby was started on caffeine citrate for the prophylaxis of apnea for prematurity. We did as per our unit policy. After the clinical examination, we did the lung ultrasound score for this patient, wherein on the right side, I forgot to label, sorry. On the right side, the anterior zones showed only the A lines. Therefore, the designated BRAT scoring for this area was 0. The lateral area showed a score of 3 and the posterior 3. Because in lateral and the posterior zone, there are only compact B lines with subpleural consolidation, therefore a score of 3. This is the left side of the left lung, wherein the anterior area showed a score of 0. Lateral and posterior again showed a score of 3 because of compact B lines with subpleural consolidation. So this lung ultrasound showed a pattern similar to an alveolar interstitial disease. The total lung score, according to the modified BRAT scoring, was 12. And the baby was administered 1 dose of surfactant, Neosurf, at 5 ml per kg. By when we had, since here, this is an AP, this is an AP view of the chest, radiograph showing the same. Herein, we had just intubated the baby and given surfactant, and by then the X-ray team had arrived. So this was just after the surfactant was delivered, and this is the AP view, wherein we can very well see the air bronchograms and the reticulogranular pattern bilaterally. Although this is a rotated film, as the clavicles are not equidistant. So this is the post-surfactant, and this is the response post the surfactant that we could make out. Clinically, the baby, the distress was better as a Silver-Anderson score had come down from 6 to 3, and also the CPAP requirements had come down. Initially, we put on the PEEP remained 5 centimeter water, FiO2 came down to 30%, and flows we could taper from 3.5 to now 3 liters per minute. Now, this is the current status for the baby. Currently, the baby is at day 16 of life and on nasal bubble CPAP of 5 centimeter water PEEP with FiO2 of 25% and flows of 2.5 liters per minute with adequate bubbling in the chamber. The CPAP interface that we're using for this patient is an appropriate size nasal mask, which is not abutting the nasal septum. The baby is being intermittently relieved of the CPAP. The KMC sessions are ongoing, and we're looking after the developmentally supportive care for our patient. Can we move to the patient bedside now, sir?
So examination, can we go bedside to discuss this examination instead of PPT presentation?
Sorry, sir?
This presentation of the baby, clinical, can we go to bedside and know the presentation?
Yes, sir. Sure.
Yeah.
Sure, sir. Yes.
Few quick questions before we
Yes,
go to
sir.
the bedside. Like you told the TP, can you go back to the resuscitation slide?
Yes, sir.
Yeah, next slide. Next slide. Yeah. No.
The next one, sir, or this one?
Next slide.
Okay, sir.
Yeah. So you chose a setting of 15/5.
Yes, sir.
You did not mention about the FiO2. What was the FiO2 given?
Sir, actually, we blended the air in the, we have a blender there in the labor room. So we were delivering an FiO2 of around 30%.
It's a blender is there.
Yes, sir. We have a blender there.
Okay. And even in the incubator, you have a blender?
No, sir, not in the incubator. Okay. So, sir, just for the transportation part, while we were shifting the baby upstairs, only at that point of time, we had no option. So,
okay, fine. Can you go to the next slide? The initial CPAP settings.
Yes, sir.
So here you chose PEEP of 6, FiO2 40, and flow 3.5. Any specific reason for choosing these settings?
Yes, sir. Sir, since traditionally we start from a PEEP of around 4 to 5 centimeter water, but since in this baby, the baby was extremely preterm, incomplete steroid cover, and clinically also the baby looked to be quite in a lot of distress. Therefore, initially, just to stabilize the baby, we chose a PEEP of around 6 centimeter water.
Usually, it is better to start with PEEP of 5 because
yes,
PEEP
sir.
of 6, the child will be at risk of having some air leaks, especially PIA. If the baby is not settling down on PEEP of 5, escalating to 6 may still be okay, but the initial choice should be 5. And someone else has also pointed out the flow of 3.5 liters looks very less. Usually, we start with a flow of 5 liters. Then we see the bubbling. If the bubbling is adequate, inadequate, based on that, we titrate further. So that is one thing I think you have to look into. Then one more thing is like ensure there is no practice of LISA in the unit.
Sorry, sir, I couldn't understand.
Less invasive surfactant therapy.
Sir, we tried, but somehow the results weren't that good, and they were. So we've switched over to now ensure only.
And the antibiotics, actually, I don't agree, not giving antibiotics for this child because mother had UTI and there is form for more than 18 hours. Like, I don't know what other units do, but I would have 100% given antibiotics without a bit of doubt also. So maybe you can discuss with, we can have input from others. Okay, the next slide.
Yes, sir.
Yeah, this is okay, fine. The next slide. So when you gave insure, what is the amount of time you kept the baby intubated? Because there is X-ray also.
Sorry, sir.
How much time did you keep the baby intubated during the process of?
So usually after 30 minutes after stabilization, the evaluation, we the baby to CPAP. But by when we could extubate the baby, the X-ray team had arrived. So therefore, the X-ray timing is that.
Actually, that by definition is not insure. Insure is you have to extubate then and there. You are putting tube only to give surfactant. Like you intubate the child, you auscultate, the air entry is equal or not, you administer surfactant, take out the tube and put back on CPAP. That is insure. If you have kept for half an hour and waited for X-ray, that is not insure.
Okay.
Yeah, next slide. Okay, again, here the flow of 3 liters looks slightly odd. Usually it is around 5 liters, what we start. Yeah, fine, next. Okay, day 16. Not interface. Okay, we can see at the bedside, I think, the interface.
Yes, sir. Nasal. Yes, sir.
Yeah. Okay, please go ahead.
Dr. Jinder, sorry to interrupt. I'm Dr. Kamal.
Yes.
So
Yes.
what happened this week, that we actually extubate the baby on an ensure within 5 minutes actually
Yeah.
after the stipulation. But actually the X-ray was done in this baby. So I told them to just wait. Let's see the X-ray, what happens. And then we extubate. So when we saw this X-ray, it was not total whiteout. Since only one dose was given, I told them to just wait for like till we get the X-ray. So by the time we got the X-ray, it was like around 30 minutes. So lung ultrasound was already showing this much of score. So I was not very sure that I should extubate this baby or should keep intubated. Like that's what happens. Sure, always.
That's fine, sir, clinically. But my objection was that she used the word ensure. That should not have been used.
Yeah, I got it.
Should have told that baby was intubated, given surfactant, then assessed and extubated. Yeah.
I got it. So because of the policy of doing a lung ultrasound now with this focus, so we are a little more sure with this thing that actually what we are is happening. So interior area lines, posterior was having subpleural consolidation and the score was going more than 8, so it was 12. So we thought that it's better to keep the baby slightly intubated further, but we extubated after, and the baby is pretty well with that. And the antibiotic issue is it's very clear, sir, because we have a very strict antibiotic policy here. Even the hospital is like very clear. You don't have a risk factors. Only 2 risk factors were there. Why did you give? So that's the main thing. So okay, over to Dr. Mahak. Already with the case now. Is it audible, sir, to everyone?
No, now it is audible. Yeah.
Now it is audible.
Yes.
Okay. So.
So the baby is receiving nasal bubble CPAP support. The room temperature is 28 degrees Celsius with a humidity of 60%. He is being cared under the radiant warmer with a set temperature of 36.6 degrees Celsius in a servo-controlled mode. And also, while I was with a 10% heater output, the cap, the CPAP cap, the nappy, and the OG tube are in place. The feeding tube is 6 French in situ and fixed at 15 centimeters. Baby is being continuously monitored under the monitor by heart rate and pulse oximeter, with no alarms being activated currently. And there was no episode of saturation of bradycardia while I was examining the baby. Clean film to prevent the insensible water loss. This baby is receiving feeds, a total feeds of 150 ml per kg per day. I've also calculated the total calories for the baby, which is the total calorie intake for this baby is 124 kilocalories per kg per day, which according to the ARP and the ACOG guidelines, the requirement is 110 to 130. So we're fulfilling that criteria, and also the baby is having adequate weight gain of around 30 to 40 grams daily. The vitals. The heart rate currently is 150 per minute. Peripheral pulses palpable, regular rhythm, and a normal volume. The central and the peripheral pulses were both examined. Then the respiratory rate is 56 per minute. Currently, there are mild intercostal and subcostal retractions. The interface that we're using for this Fisher paper for the nasal double CPAP is a nasal mask, which is not abutting the nasal septum or the nasal bridge. And this is the inspiratory and the expiratory limb of the patient. There is adequate bubbling in the chamber. And we're delivering a PEEP of 5 centimeter water. The flows that we're giving through a low flow system is 2.5 liters per minute, and FiO2 requirement is 21%. As we are achieving the required SpO2 of 98. The required is 91 to 95, but on 21% FiO2 also the saturation is 98%. Therefore, that was the least we could taper to. Now the temperature, the axillary temperature as was measured by the digital thermometer was 36.6 degrees Celsius, which matches with the servo control temperature monitoring on the warmer. The peripheries are warm to touch. The CFT measured at the sternum is 2 seconds. The SpO2 as mentioned is 98% on an FiO2 of 21%. Then, according to the new Ballard scoring system, gestation as assessed by the extended new Ballard scoring corresponds to 28 to 30 weeks of gestation, which is within 2 weeks of gestation based on the LMP. The anthropometry parameters, weight of the baby at birth was 1160 grams, which lied between the 50 to the 75th centile as is mentioned on the, as has been plotted on the Fenton chart. The length at birth was 35 centimeters and head circumference was 26 centimeters. So this baby was appropriate for the gestational age. The present weight of the baby is 1190 grams. The baby has crossed the birth weight and attained the birth weight by day 14 of life. That is a normal time. Today is day 16 of life. The length is 37 centimeters by infantometer, and the rate of increase that we've achieved is 1 centimeter per week, which is within the normal range for a VLBW baby. The head circumference of the baby is 26 centimeters, was 26 centimeters at birth. Now it is 27 centimeters, and which is falling between 10 to 25th centile as per the Fenton chart. And the head growth is within the normal range, which is 0.75 to 1 centimeter per week. The ponderal index for this baby is 2.7. On the general physical examination, when I examined, the oral cavity is healthy. There is no feature of any oral thrush that was evident. The umbilicus is healthy. There is no discharge or redness around the base. Also, the eyes, the conjunctival sacs appear to be healthy. There is no discharge or redness noted. There is no, the skin is also appears to be normal. There are no petechiae, ecchymosis, superficial skin infections, or scleremia for this patient.
That's it, I think.
I think you can cover up the baby because the baby may become cold.
Cover up. Skin out.
Can you show the humidifier?
Is it visible, sir?
Yeah. So I can see it is 37.5 degree. Can you long press the mute button? Yeah, long press. Again, can you long press? Yeah, 40. Can you show the water level in the humidifier? It's there till the line. I think it's less.
Sir, because it is an auto filling, so जब वो थोड़ा सा कम हो जाएगा, then it auto fills it.
Yeah. So from where we are filling, just can you show that? Okay. I hope there is no air in the tubing or anything.
No, sir, there's no air.
उसको था.
Okay, I will discuss in detail about this humidifier thing. Yeah. So just one suggestion before we start the discussion.
Yeah.
We should not be exposing a preterm baby for a long time like this. Better we discuss everything around only for the examination. Like you examined for the CFT, you counted the rate, and you saw the pulses. For these three, only for these three, maybe we can expose for a minute and then cover back. That will be more ideal. Because if we keep it exposed, no, that's not good for a preterm baby because they will lose that micro environment.
At that time, we could see that the heater output was increasing actually.
Yes,
I was
yes.
seeing that. I didn't interrupt
So
that time.
Because there are now a lot of things you have done rightly by putting the cling wrap, then covering the baby. The advantage will be lost once you open up. Yeah, that's all. So we will start with the vitals. I think your vitals are okay. Heart rate was okay, respiratory rate was okay. Saturation you told is 97, 98. So someone was asking in the questions also, is that okay, 97, 98%?
The ideal saturation that we target for neonates is 91 to 95%. But we are only delivering an FiO2 of 21%. Sir.
So basically that is the point, because you are giving 21%, even if it is 100% oxygen saturation, it is acceptable. Okay. And what are your alarm limits? What alarm limits did you keep for the SpO2 in your alarm, in your monitor?
So we keep it anything below 91% beep, sir. So
No,
our target.
As of now, what is the limit set in your monitor?
It is 85 to 100.
Yeah, maybe that is okay. That is okay. But if suppose the child is on 25% or 30% oxygen, what will be your alarm settings?
What will be your alarm settings if like you're on 30%, 30%, what will be your alarm limits?
So since our target saturation is 91 to 95, so it will be 90% above, below which the so 88 to 96% will be our target, sir.
That is okay. Even 95 or 96, either of them you can use. And this is very important for all the fellows or PGs, whoever is attending the session. The alarm limits have to be targeted. Okay. And you have to ensure that the probe is always on the right hand. When a child is receiving supplementary oxygen, anything more than 21%, your saturation target should be 91 to 95. So alarm limits maybe plus or minus 1 you can put. Suppose like 89 to 95 if you put, that is fine. 96 also if you put, it is fine. But once you change to 21%, then you should increase the upper limit to 100%. Otherwise, your alarm will keep on ringing unnecessarily. Okay. So that is one thing. So it is commendable that you are giving 21% oxygen. That is a very good thing. Then I wanted to ask you about the flow. The flow is actually not adequate. So what do you mean by an adequate flow? How do you tell that flow is adequate? On what basis you will tell?
There is adequate bubbling in the chamber and the patient requirements are getting fulfilled. Bilateral is equal. There's no.
What do you mean by adequate bubbling? That is what I'm asking. What do you mean by adequate bubbling?
So there is no leak. The interface, the CPAP interface is in place. There are no leaks, and the gas exchange is occurring. And
no, gas exchange is occurring, but is that because of CPAP or despite CPAP? So that is what I'm trying to ask. Ideally.
Auscultation also, sir, we confirm that proportional to the adequate bubbling in the chamber, there are air entries. Auscultation confirms
so
it.
What I'm trying to ask is, what is that adequate bubbling? You're telling
sorry to interrupt, Dr. Bahek, Dr. Rajendra, sorry to interrupt. You got another few minutes only, so I will request to discuss something which is very, very clinically bedside.
So
otherwise, Dr. Monica's presentation is there. After that, regarding CPAP, many things we can discuss to present 30 minutes again.
So we have only 3 minutes.
Bedside assessment, something like bedside retraction, scoring, or anything clinical examination.
Fine.
Regarding to CPAP, we can go back to after the presentation of Dr. Monica.
Sure. So adequate bubbling is there has to be continuous bubbling in both inspiration and expiration. The minimal flow at which there is continuous bubbling. So
Yes,
when we
sir.
saw that there was no continuous bubbling during one phase of the breathing, it is not there. So ideally we have to make it, maybe you have to increase the flow a bit. Okay. And what other interfaces do you know which we can use for delivering NIV?
So there can be nasal masks that we're using right now, or nasal
Yeah.
prongs also available. Hudson or Argil nasal prongs are also available. But as per our unit policy, we're using mask. As when we were using the prongs, there was quite a lot of nasal injury with the nasal septum and the columella being injured. So
Yeah.
currently we're using nasal masks. So
So there are many options which we can use. Nowadays, people are even using
there are short and long nasal masks.
Yeah,
Sir.
short
Short
and
by nasal and the
nasal
long
trunk.
nasopharyngeal
Exactly.
masks also.
Yeah. So KMC, you are able to give with the mask?
Yes, sir. Mother is coming after. So we motivate KMC right from the beginning. Antenatal counseling also we include KMC and motivate mothers to carry on the KMC session. She's been visiting regularly, and baby is being handed over to her in the
Okay,
for KMC.
that's good. And I think your nutrition practices are appropriate. You are giving, I think, 45 ml of around 150 ml per kg.
Yes, yes, sir.
So you are using human milk 45.
Yes, sir. Yes, sir.
Yeah.
We're giving HMS, sir, for this baby 150 ml per kg per day, so around 7 sachet per day to achieve an adequate calorie intake for 24 hours.
How much is the calorie intake?
For this baby, sir, we have calculated. We can. So the feeds, if it is visible here, the total calorie intake, since the feeds are being administered at 180 ml per kg per day, so we are giving 17 and 18, 6 feeds to hourly. The calorie that we are achieving from only the EBM is 120.6 kilocalories in one day. So we're using sachet HMF, one for each 25 ml EBM. So total 7 sachets are delivering 23.5 kilocalories in one day. So total of 144 kilocalories per day, which is 124 kilocalories per kg per day.
Okay, sir. I think we can close it. It's 8:40. You can go to the next place.
So, Dr. Mehik, your session is not closed. You can come back to the presentation site. So bedside is discussing over. After Dr. Monica's presentation, we will combine the questions depending on the areas. You can again direct the questions to both of you. You can answer your areas, the bedside clinical examination or the clinical application. So I will request Dr. Monica to start the presentation. So as it's already
Meanwhile, Dr. Monica, please upload your presentation, share your presentations. Thank you, Mahak. You presented very well, and I must congratulate your mentor, Dr. Kamal Arora. I think you did a fantabulous job. So, Dr. Monica just joined a neonatology fellow under NNF just 3 months back. So, let's start. So, she is going to present the application of CPAP in neonate, more of a clinical use. So, Monica, please use full share. Yeah. Okay. Go ahead, please. Monica, your voice is not coming.
Yes, sir. Am I audible now?
Yeah. Go back from first slide. Yes.
Yes, sir. So good evening, everyone. I'm Dr. Monica, presenting application of CPAP in neonates under the guidance of Dr. Kumar sir. So let's start our slide. What is CPAP? CPAP is a form of non-invasive ventilation where positive pressure is applied to the airway of a spontaneously breathing infant throughout the respiratory cycle and thereby preventing the collapse of alveoli and terminal airways during expiration. So let's see the physiological effect of CPAP. As we can see in the following graph, volume versus pressure graph, we can see that when the pressure is at the lower side at 3 peak, if we increase in pressure, there is only slight change in the volume. However, once the pressure is raised up to the critical opening pressure point, the alveoli opens and there is a large change in volume with slight increase in the pressure. So this is the optimal FRC which we achieved by the use of CPAP. This is the FRC which allow for optimal gas exchange and ultimately leading to the ventilation perfusion, good ventilation perfusion. However, if the pressure is increased to a higher side, more than this, then it can lead to the high FRC and can lead to the overexpansion of the alveoli, leading to the overdistended lung and can lead to the complications like air-like syndrome. So by the use of CPAP, we attain this optimal FRC for achieving good gas exchange. So PEEP basically, it distends the alveoli and prevents the collapse of alveoli, thus leading to the good gas exchange. CPAP, it also splints the upper airway and also stretches the lung pleura, so decreasing the risk of obstructive and as well as the central apnea. If you talk about the components of CPAP, it includes a gas source, a pressure generator, and a nasal interface. Gas source to provide the continuous supply of blended gases, that is air and oxygen. And as we know that this compressed air gas source is very cold and dry, so it need to be properly warmed and humidified using a humidifier. Pressure generator is used to create a positive pressure in the circuit, done by submerging the expiratory limb into the water chamber. Third is nasal interface to connect the CPAP circuit to the infant's airway. This pressure generator can be of two types, either the continuous flow devices type or variable flow devices. Continuous flow devices basically create pressure against the obstruction of a fixed flow of gases during inspiration as well as expiration. It includes ventilator CPAP, where pressure is created by the partial closure of expiratory valve, and in bubble CPAP, pressure is created by submerging the expiratory limb into the water chamber. Variable flow devices include IFT and Y-size CPAP, where pressure is generated proximal to the nostril. Out of these all devices, NNF-CPG recommends that bubble CPAP have an advantage of pressure oscillation, so maintaining better gas exchange, and that preferably be used in preterm neonates requiring CPAP for any indication. However, the strength of recommendation is weak and with low to very low quality of evidence. Various options available for nasal interfaces are Argel prongs, Hudson prongs, nasal mask, and ram cannula. However, the guideline says that nasal mask, either the short binasal prongs or nasal mask should be preferred for particularly in the neonates at a high risk of nasal injury with strong strength of recommendation and moderate quality of evidence. So we use binasal short prongs or nasal mask which deliver the exact CPAP in the oropharyngeal pressure as we have said in the bubble chamber. Now, indications of CPAP, the prime indication is the baby should be spontaneously breathing. In preterm neonates, CPAP is indicated in any respiratory distress with Silverman score equal to or greater than 3, in recurrent apneas or post-extubation. In term neonate, used in any respiratory distress with Silverman score more than 5 or post-extubation. And as we have seen, the CPAP also splints the upper airway, so it can also be used in airway malformations like tracheomalacia. Now look at the evidence as per NNF CPG 20 guidelines that when CPAP is used as an initial respiratory support, all preterm neonates with respiratory distress should be managed with CPAP. They show the strong strength of recommendation with low quality of evidence. However, there are small possible risk of air leak in neonates CPAP started on CPAP therapy. So facilities offering such support should have expertise to monitor such neonate to avoid complications. Another evidence for that CPAP should be administered at or immediately after the onset of respiratory distress in preterm neonate shows strong strength of recommendation with low quality of evidence. CPAP therapy should be initiated in preterm neonate with apnea of prematurity in conjunction with methyl xanthils, showing strong recommendation with low quality of evidence. Preterm very low birth weight neonates being extubated after a period of ventilation should be weaned off either to CPAP or NICV, showing strong strength of recommendation with low to moderate quality of evidence. So as we are talking about CPAP, so we start talking about right from the delivery. As per European Consensus Guidelines says that spontaneously breathing preterm infant should be stabilized using CPAP with A1 recommendation. If newborn is apneic, then start mask ventilation with CPAP pressure of at least 6 centimeters of water with PIP of 20 to 25 instead of intubation. Earlier in the disease course, CPAP is started, better are the outcomes, reduces subsequent minute ventilation and PPD. Here is an evidence from the large 4 RCTs where 2,782 babies are enrolled. This published in JAMA publication shows that when soon after the delivery, if baby is breathing or crying, then we allow to delay cord clamping for 60 seconds and then look at the baby. If baby is having respiratory distress, signs including like grunting or retractions, then instead of intubation, start with CPAP with 6 centimeter of water. It shows that there is decreased risk of mortality, decreased risk of BPD. With number needed to treat is 20 to 25. Mean to say that if we treat 25 newborns with CPAP, we can prevent extra 1 BPD. So now the how to initiate CPAP. So first connect the baby to a pulse oximeter, fix the cap size, use the right size prong, either Fisher and Paykel or Hudson, then check the circuit, connect the CPAP circuit to interface. After connecting, insert the OZ tube in such a way that the tip should be open and it should be kept at a level above the level of abdomen. So initial settings for bubble CPAP, we start generally with 5 centimeter of water and with FI to 50% and with flow at least 5 liters per minute. However, this is not a strict rigid rule of 5. We can titrate this depending on the clinical assessment of the newborn. So we can titrate flow. Flow, it must be enough to generate minimal bubbling during both inspiration as well as expiration, which is achieved at a rate of 5 to 7 liters per minute. FIOT can be titrated between 21 to 60% to achieve the target saturation of 90 to 95%. CPAP can be titrated between 5 to 8 centimeters, depending on the retractions and chest X-ray and saturation. However, chest X-ray is optional, not mandatory for every newborn. Chest X-ray can be done in a newborn to assess the low FRC or to assess the lung volume. If baby is having low FRC, so we can increase the CPAP. And if you're having adequate FRC, so we can decrease CPAP accordingly. So in this first X-ray showing the low FRC, it's very difficult to delineate the lung, heart, and liver borders, showing very low FRC with anterior ribs showing only 4. So for adequate expansion, at least 6 to 8 ribs should be visible. So apart from providing pressure, oxygen, and flow, the gases should be warmed and humidified. Inspiratory gases delivered at NEA should be at temperature of 37 degrees Celsius with relative humidity of 100%. No condensation in the inspiratory circuit is acceptable. However, some condensation in the expiratory limb is acceptable. So this diagram showing display of 37 degrees Celsius temperature in the humidifier, and this showing there is slight 1 to 2 degree increase in the temperature while the gases flow through the inspiratory limb and ultimately reaching at the level of Neris at 37 degrees Celsius. So while baby is on CPAP, we have to continuously monitor the patient, the machine, as well as the interface. Monitor the vitals of patient, heart rate, respiratory rate, including SS score, saturation, air entry, and bubble. Monitor CFT, BP, urine output, and abdominal girth. Monitor the machine, look for the pressure, FiO2 and flow, look for water in the humidifier, bubble chamber, and condensation in the circuit. Look at the interface to look for major injury and secretions or adequate CPAP size and prong size. So when we can say that CPAP is adequate, if a baby is on CPAP and having satisfactory cardiorespiratory status, including baby is comfortable with minimal retractions and no grunting, with normal CFT and BP, maintaining normal saturation 91 to 95%, or normal ABC, however, not mandatory, not done in every patient. And there should be bubbling present in the bubbling chamber during both inspiration as well as expiration phase, and bubbling breath sounds are audible in axilla. So once the baby has improved and stabilized, then we can start the weaning as soon as possible. Decreases the FiO2 in steps of 5% to 30%, and then decrease the CPAP pressure in steps of 1 centimeter. Maintain CPAP to 5 centimeter till FiO2 is 30%. For every 10% reduction in FiO2, aim for reduction in CPAP by 1 centimeter. Subsequent reduction in CPAP is done to 4 centimeter only when FiO2 could be dropped to 30%. If CPAP is pressure is 4 centimeter and FiO2 is less than 30% and disease process has improved, baby is clinically well, then we can remove the CPAP or can shift to the high flow in case of extremely low birth weight babies. So when CPAP is considered to be failure, however, always first ensure optimization before labeling CPAP failure. So a baby is said to be in CPAP failure if having continuing retractions, grunting, or increasing SAS score, if baby is having recurrent apnea and not maintaining saturation even at the PEEP of more than 7 or FiO2 more than 60%. However, this is different from the European guideline, which suggests indication of surfactant replacement therapy when FiO2 requirement is more than 30% on CPAP pressure of more than 6 centimeter of water. And CPAP is also considered to be failure if baby is not tolerating CPAP or having poor respiratory efforts. So reasons for failure could be either the failure of CPAP system, or if the worsening of baby is due to the respiratory condition or due to air leak syndrome or due to cardiovascular instability or neurological involvement in progressing to encephalopathy. Contraindications of CPAP includes if baby is having poor respiratory effects, congenital diaphragmatic hernia, tracheoesophageal fistula, or upper airway malformation like choanal atresia and cleft palate, or cardiovascular instability. Complications of CPAP includes nasal injuries or including respiratory, cardiac, and GI complications. Nasal injury can include the nasal septal injury, nasal bridge injury, columnar transections, or columnar injury. Respiratory complications may include if we use higher pressure, then there are chances of increase of air leak syndrome. Cardiac complication includes cardiovascular system instability leading to hypotension, and GI complication including CPAP belly syndrome or feeding intolerance. So do not take CPAP lightly, continuously monitor the baby. So nasal septal injury is preventable, can be done by careful observation using correct prong size, correct prong positions, and maintaining gap between prongs and columella and with effective attachment. Sorry.
Monica, just have some water and then you can come. Are you fine? Are you okay? Okay, go ahead, please.
Yes, sir. Sorry, sir, for interruption.
Not issue, not issue.
So another complication can be air leak, as we have seen in the diagram. If we increase the pressure to a very high side, it can lead to the overexpansion of lungs and can lead to air leak. So monitor flow and CPAP pressure accordingly. Now, some common troubleshoot when the patient is on bubble CPAP. First, it could be the desaturating baby. It could be due to the either displaced, distorted prongs or obstructed nares, and could be due to pneumothorax or equipment failure. Another, it could be an absent bubbling, which can be due to either complete or partial circuit leak, or can be displaced prongs, inadequate flow through the circuit, or prongs are too small for the baby. Or agitated baby. So always watch for the nasal injury and secretions. Minimize the handling of newborn. Careful interface application and effective airway clearance. Do clustering of care and can feed the baby. However, sedation is not recommended for agitated baby on CPAP. Common troubleshoot on bubble CPAP can be diagnosed on the basis of saturation, retractions, air entry, and bubbling. So if a baby is having low saturation with moderate to severe retractions with poor air entry, however, bubbling is present, then it could be due to the severe lung disease. If baby is not maintaining saturation with nil or minimal retractions with good air entry and bubbling, it could be due to the CST or PPHN or blender malfunctions. If baby is maintaining normal saturation but having moderate to severe retractions with good air entry and bubbling, then it could be due to the metabolic acidosis. If baby is having low saturations and moderate to severe retractions with poor air entry and bubblings are present, then it could be due to the nasal obstruction. If baby is having low saturation, moderate to severe retractions, and poor air entry and bubbling are absent, then it could be due to the leaks. So this was all. So thank you.
Thank you, Dr. Monica, timely completing the presentation with covering all the aspects of the bedside care, CPAP care. So I will ask now again Dr. Rajendra, Dr. Ankur, Dr. Kamaldeep to just go through the discussion. But we take up questions actually. Very well presentation. Such a timely covering all the aspects, Dr. Monica. And the clinical presentation was so good actually. It covered all the, Dr. Mehak covered all the clinical aspects in bedside presentation with a clinical background. So both presentations are very nice, very clear, crisp presentation for the students. But Now to learn better, I will request all the three faculties, and Dr. Aparna Prasad also available to us today. She has joined. So I will request any of the faculties, can any inputs, any questions? Then we will go to the audience questions, the students' questions, we will go to that and to answer.
Yeah, I second to what sir has told. It's a nice presentation. Even the first case was well presented. I think we can directly go ahead with questions. I don't have much comments on the presentation. It was crisp and nice.
So, either Dr. Kamaldeep or Dr. Kumar Ankur, both of you, can be any suggestion, any questions?
First one, Dr. Mac, you presented it very well. So
Thank
as Monica has presented that the guidelines are going towards that you should use a PEEP of 6 cm. Dr. Rajendra has already told that you should start using PEEP depending on the baby's clinical conditions. So how do you decide, I mean, how much PEEP you should start right in the delivery room? Let's start from the delivery room. Like in your case, my mom had already received antenatal steroids and baby had distress right soon after birth. So, I mean, how should you approach to a baby with a 28-weeker or near the ELBW baby with respiratory distress?
So traditionally, a PEEP of 5 centimeter water is used for the premature babies. And since our intrinsic PEEP in the newborns is 3 to 4 centimeter of water, so we aim a higher PEEP of around 5 centimeter, as I mentioned, is traditionally used. But in our baby, since during the transportation, while we were giving the TP's resuscitator and the baby was in 5 centimeter water PEEP for quite a while transportation, therefore, and the distress was quite a lot. Therefore, we chose to give a 6 centimeter water. But otherwise, our unit policy also is 5 centimeter water of PEEP that we generally use for all the babies in our unit.
That's great. So we start from the 5 centimeter water. That's a good. So you increase to 6 centimeter water and don't give, and then you shift the baby on 7 centimeter. So if you're using a 6 centimeter of PEEP, so which interface you use right in the delivery room and during the transport? So have you started with delivery room CPAP with mask? So your baby was shifted on incubator for transport in the NICU. Which interface you use? You use Ram's cannula, you use a nasal prong, because it's very difficult to transport a 28-weeker baby, with a simple mask.
So actually,
can you recollect that on which interface you transported the baby, or generally on which interface you transport the baby?
only interface that we're using is actually the mask only. So we connect the mask via the new puff circuit to the new puff machine, and this is the only. So it's actually, I'm very clear with it. So
that's great. That's great. If you are able to transport the baby with a mask and T-piece, 28-weeker, then it's great. Generally, it's very difficult to transport because there are high chances that you lose the mask leak and your baby won't be getting adequate amount of it. I think the Dr. Rajendra and Dr. Ali can comment and Dr. Kamal can comment. So that means generally either you use Ram's cannula for transporting the baby because you get adequate. So if you're using different interface, so you will lose some amount of PEEP, because if you're using Ram's cannula, generally baby would get -2 centimeter of whatever you achieve. So that's how the de-recruitment happens. What Monica had told you that in PV loop, you must have seen that. See, if you recruit the lung, it takes time to stabilize. Specifically in ELBW and VLBW, they take time to stabilize. Your lung takes time to recruit and they get stabilized. But if you lose the PEEP, that means you are getting atelectasis, opening and closing of alveoli. They could create a lot of injury and they can damage. So Dr. Rajendra, you can add something on Nalini?
Yeah, I agree with that. Transportation is a major challenge on this.
Dr. Rajendra, just quick request to Dr. Monica. Please stop sharing the PPT so we all can interact in the screen.
Yeah, stop sharing PPT.
Yes.
Perfect. Thank you. Thank you. Now please go ahead. All can go ahead.
So transportation is a major challenge with respiratory support. I agree with what Dr. Ankur was telling. So we can use a Ram's cannula, especially if the transport is for a prolonged duration. But in some units, maybe the labor room is right in front of NSU, then I think you can shift on the T-piece itself. Like we can put the T-piece to the, but if it is quite long, like especially if it is extramural transport, the baby has to go from one building to another, then it is quite challenging. And errors are common, especially when we disconnect from the central supply and connect to the cylinder. Sometimes we set up very high flow, the high unregulated flow, and we saw many babies developing pneumothorax in the process also. So we have to be very careful.
So I have a suggestion here for the process of transportation and a question to Dr. Mehek also. So two components actually. I will take a little privilege here to continue the discussion here. Dr. Mehek initially written in the delivery room CPAP, a T-piece resuscitator, when she used default settings, she used 15/5. I think difficult to agree. I will ask other faculties also opinion. A setting of 15/5 across difficult gestational age with difficult poor compliance lungs, is it okay? Is it the NRP recommendation or is it okay to use? Because if I will use with a lower pressure, manage the baby, I will happy. But if I will age equally, I am anxious. If I use 15/5, I'm not able to recruit the lungs. And within few minutes, somebody intubating, then I failed. So when the smaller babies, people standard setting of 20/5, but they used to avoid intubation. Some of the trials and evidences generated, you go to 22 to 25/5 for a few minutes, recruit the lungs, come back to 20/5, avoid intubation, we did a great job. You avoided surfactant. But putting a lower pressure use in the neopop, but ending into surfactant or ending it to intubation, we lost the advantage of delivering CPAP. Probably all the faculties will agree because standard recommendation says 25/5. So is it okay to send a message to the audience, delivery room, neopop you are setting before the baby comes out, probably flow of 8 to 10 liter, FI to 30% to 21%, depending on your need, if a blender is there, and at 20 PIP, 5 PWP, by default setting, you can start, you can use according to your baby's need. Is it okay to recommend this way?
Yeah. True, Dr. Lanili, I do agree with you. I think, see, the bad is the gestation. I mean, the bad would be the lung. In that case, your initial pressure would be high. If you lose that few minutes of the life and I mean, your lung gets derecruited, that means the need for intubations, need for surfactant, and a prolonged, I mean, disease. I mean, we all are discussing about the chronic lung disease would be high. So the idea and message should be clear. I think most of us are on the same page. So, okay, Dr. Mahak.
If I correctly
sir,
remember,
absolutely.
Transport one experience, I will say, to make
Yeah,
it
please.
clear.
Yeah.
One is delivery. We do use incubator, ventilated transport, whenever one facilities to other facilities, and investigation to the clinical area to the investigation area, from the delivery facilities to the NICU, we use because we are in different floor. I will say what are our challenges and how to use it. As Dr. Ankur raised the question, Dr. Rajan also asked question. T-piece resuscitator, you are stabilizing the baby by face mask, perfectly fine. Transport, as Dr. Ankur is so told, is anxious about transferring a baby without displacement with the face mask, little tricky. So what our experience, I will say, stabilization with face mask, that's a standard recommendation. If I'm transporting the baby across facilities, across room, across building, probably Ram's cannula will be a better option if with a prong, which we can see fit well, displacement, dislodgement is later. So we have almost, I can say 159 babies we have transported from different facilities for the CPAP with Ram's cannula only with neopop. But we have, along with neopop, we have the ventilator, dedicated ventilator CPAP in the incubator. That's also the face mask. Instead of face mask, we can use nasal mask or nasal prong. You got a machine in the incubator, the ventilator CPAP is there. We can use either standard nasal prong or nasal mask, but we don't have that. T-piece resuscitator only we are using. Probably the Ram's cannula will be an option. But what I will say, for the smaller babies, less than 28 week or 27, 26, 25, 24, when we are transferring, we use humidification system along with T-piece in the delivery room. We use humidification system. When the humidification system, we use the circuit. The circuit can have a face mask, not nasal mask. So nasal mask, circuit, humidification, and the blended neopop, we can carry to the NICU. If you have all the circuit, go for nasal mask. You don't have all the circuits, still the nasal prong in Ram's cannula can be do. Your dedicated machine, use your standard mask and prong. So depending on a machine, we can choose the interface. Face mask will be a little tricky because repeated displacement is possible. So these are delivery room 2 practices. I thought I will give my inputs. then I will request again for the continuing
So
demonstration.
very well explained, Dr. Nandini. So just shifting from delivery room to transport and transport to NICU. So let's suppose, I suppose that this seminar is meant only for CPAP. So I won't switch like to bus just for the clinical point of purposes. So like in this case, 28 weekers, somehow in between we do discussed about the Lisa. So could this baby be shifted on the NIV mode to avoid the intubations and giving surfactant in less invasive way, Dr. Mahak? So we will
Sorry.
keep it very short because we are not going to detail. That's entirely a different topic. NIV, I mean nasal intermittent positive pressure ventilation or non-invasive NIV. You got my point or not? No.
Sorry, sir, I
So
couldn't
it's
understand.
okay. So Nalini, let's leave this NIV part. I think it's a big part. So let's go. Dr. Rajendra, please. I think you have.
Coming up NIV, primary and
So
post-extubation.
yeah, so
There
we'll
to go for-
discuss. Yeah, we need a.
Yeah.
So Doctor.
Regarding the pressures, I wanted to just make a point. If we go according to NRP, it tells 15 to 20 as the beginning pressure for preterm and 20 to 25 for term. This is about the PIP. PEEP, they tell it is 5 to 6, so we can choose. But as Dr. Nandikant sir has told, it has to be case to case. We can't have a blanket thing for every baby I will start with 15 or for every baby 20.
So one thing again, I will take the question from audience. Audience are little repeatedly asking one question. What is the right pressure? We know there is no cookbook, no fixed pressure for the CPAP. We all understand that. Disease is different. Dose of the medication will be different. And titration of PW for CPAP is a dosing pattern actually. Severe the disease, little higher. Lighter the disease, lesser the disease, probably lesser. We understand that. But as the audience and student want to learn, what as a faculty we should give them the message, what to start with, because always the titration comes later. Start with, probably we agree, the 5-liter flow and 5-liter pressure will be probably ideal in the many of the cases. If requirement is there, if the FID requirement going up or the worker breathing is going up, probably we can go to 6 and 7 depending on the unit policy. But I think message to all, 5 and 5-liter flow, because the flow regarding all questions came, 2 questions came regarding flow. Yeah. Why use 3, why use 3.5? Why use 2.5? Are we titrating depending on the PWP, the flow little lesser? That question came. So make it simple, 5-liter, 5 CPAP. But if required, we can go to 6. Probably the student way, the learning way can be started that way. And again, I already agree, no fixed policy there, no fixed protocol. And retraction is there, intercostal retraction there, workup breathing more, Silverman-Anderson score is higher, and the FI to need is higher. Go little up. And it is, but settling down, we can come down. But to start with 5 will be fine. Here, one thing, Dr. Rajendra also, I need inputs, both Dr. Ankur and Dr. Rajendra, one inputs, flow regarding, my understanding, when the Fisher-Paykel, they ask as per the protocol workbook of the Fisher-Paykel company itself, they say before starting to the baby, like a ventilator, you're putting test lungs and testing that, is it going to work? So they say, block your prong, block your mask, and put 2 liter, that is the minimum flow, and see that is it generating 10 pressure, bubbling is there or not. The efficacy of a machine, even everything leaked out from the mask, if it comes down to 2 liter, still is it generating the highest capable PWP? Doing, the circuit is intact, it is working. That's the guideline talk. So before starting, we can check it. So that way, if a 2 liter also can generate 10 PWP, if Dr. Mehek is putting 2.5, 3 liter, is it not okay? Is it not right? To 5 liter, it can generate 5 cm. It can generate 6 cm, 3 liter also. So why that default design of 5 liter to get to make it simple or some physiological basis? So I'm taking inputs from all the faculties, including Dr. Kamaldeep, because Dr. Mehek presented practically whatever she has seen, she presented. And the protocol itself says 2 liter also can generate 10 cm PEEP. So she is wrong, or physiological, which can be better for the learning process. But both Dr. Rajendra, Dr. Kumar, and Dr. Kamaldeep.
I think let's Kamal, please
because
go ahead.
We presented that case, sir. We have 2 flow meters. One is a low flow meter and one is a normal flow meter, which is still from 0 to 15. We specifically asked for a low flow meter from 0 to 3.5 because we were getting a very good bubbling at 2.5, 3, 3.5. So for this patient, it was like bubbling was very good at 3. So we didn't increase it because the risk of pneumothorax would be high if the baby is now 16 days. Baby is now trying to actually fight with the CPAP, and we actually shift this baby for some time to even the nasal cannulas. That is high flow cannulas also on the same circuit. So the Fisher and Pickles, they give that, the company gives that HFNC cannulas. So I go with your answer that minimal flow should be given so that the Rio trauma, which we want to prevent with the ventilation, should be decreased. And because Dr. Jinder said that, I didn't contradict at that point, because 5 was a conventional teaching. Even for a PEEP of 3, 4, 5, any where we get the good PEEP, I would be happy with that. So like for this baby, we started with a 6 because we were expecting, because retractions are increased. So we started with a 6 in this baby. And we could lower down after surfactant only, not before that. At one point of time, we had to reach actually till 7 also. But because Ensure was given early as early rescue, so we decreased to 5 early, the risk of pneumothorax to decrease the risk. So minimal settings of everything, the FiO2, the flow, the PEEP should be used so that we could decrease all the atelectotraumas, the barotraumas, the rheotraumas, oxytraumas should be decreased.
Kamal, can I interrupt one point?
Yeah, Dr. Kamar.
Okay, so as far as flow and the bubbling is concerned, first, I think most of the studies were done when they use the flow meter along with the humidifier chambers. So you have all the cylinders, they have the humidifier chambers. So what we have found that if you use the flow meter along with your humidifier chamber, you need very high flow to generate the bubble. So for last 5-7 years in entire hospital, we are not using humidifier chamber with the oxygen flow meter. Okay, so we directly connect the oxygen tubing to the flow meter. So what we found that even with a small flow, maybe 2 liter, 2.5 liter, we generally get a bubble of both during the inspiration and expirations. So that's why the Fisher Pickle, they studied all this with this humidifier chamber. So nowadays, because you are using centrally supplied compressed air, oxygen air with a flow rate of even 2, that's why I mean Kamal is right. So even with a small flow rate, you can get the bubble. Okay, if you are not reading that humidifier chamber. So what Mahak shows that, so in your blender area, the humidifier chamber was there. That's a useless humidifier. They won't work at all. They can lead to a lot of fungal infections because you have to add distilled water every day, you have to change it. They don't work at all. So even the evidence is not favoring that, because all the humidification is being done by a humidifier chamber. So you can remove this and you can directly attach your oxygen flow. Second, the moment you increase the flow rate, what Dr. Kamal has told, that will increase the resistance, rheotrauma, and it directly proportionate to the PEEP value. That's why we have the safety device in all the CPAP, the pressure release device. So that's why even if you increase the flow rate, you will get that amount of PEEP, whatever you have set in the ventilator or what is the submerged in the water. So even with increased flow rate, you will get that same amount. What Nalini was showing that telling that if you increase the flow to higher level, you can achieve a higher PEEP also. To safeguard this, we have safety device there. I think most of you are using the humidifier chamber or not, I don't know.
Great discussion. The flow regarding, pressure regarding, always after so many years.
I will answer.
Yes,
if you give me a moment.
Yeah, please, sir, go ahead.
So as per what we are all discussing till now, we usually start with 5 liters flow and 5 PEEP and FiO2 of 30 to 40. Some people used to start with 50, but now the trend is more to start with a lower FiO2 of around 30 to 40%. And the flow 5 is not fixed. That was not my message, what I was telling previously. We always start with 5 and then we look at the bubbling. Okay, if there is continuous bubbling, so we have to choose the minimal flow at which there is continuous bubbling in both inspiration and expiration. Suppose if there is an interruption in bubbling, that means the flow is inadequate. We are causing rebreathing and air hunger, and in the process, there will be some collapse of the alveoli. So that has to be taken care of. So that can be 3, that can be 2, that can be anything, but there has to be continuous bubbling. And one more thing, on the other hand, if we are requiring a higher flow, suppose we require a flow of 7, 8, 9, 10 to have that continuous bubbling, then it indicates that there is some leak in the circuit. And the commonest place where leak can happen is the interface. Usually we choose snugly fitting. We are supposed to choose snugly fitting interface for CPAP. And if it is not snugly fitting, there can be significant amount of leak. And sometimes there can be leak in the circuit. Actually, it helps us. Like if you are required to give flow of 8 or 10 to achieve that bubbling, that means there is something wrong with the entire circuit, there will be leak somewhere. And I agree with you, like sometimes we also have seen that at flow of 3.5, there is continuous bubbling. Till there is continuous bubbling, there is no issue at all. But if there is not continuous bubbling, then that's a problem.
So that's the message. I mean, you need a continuous bubbling, whatever rate is there.
Minimal flow at which there is continuous bubbling. Suppose you are
great.
getting continuous bubbling at 3, you put 3, no problem.
Okay.
This continuous bubbling, very to understand very clearly, Dr. Rajendra told in the bedside, it should happen continuous means during inspiration and expiration. Because we have seen many times, expiration time bubbling happens because of the babies pushing air into the circuit. That's not the real bubbling. If the inspiration and expiration both time bubbling happens, that's our goal. So interruption in the bubbling, probably we are getting inadequate flow or the leaking is there. So that point, probably all the student when going bedside round should observe that this bubbling, what I'm listening, is it continuous throughout the both phases of respiration? That should be the clear message. Prasad is saying from beginning on the bedside, that probably one thing to observe when we are going bedside. So, but here the flow regarding we discussed, the PWP we discussed. So few of the questions now we can take, unless specific questions we will get from faculty. So I will take some of the questions from here. So regarding flow, some of the questions already asked, which are answered. So one of the question came from Dr. Purushottam Bhandari. Any of our faculties or our presenter can take, is it better to start at lower FI to increase if needed, or start at high and decrease? Dr. Ankur, can we give some guidance to the...
See, if you start right in the delivery room, we all know that we follow the resuscitation guideline. So anything less than 35 weeker baby, you start with 21 to 30%. Okay, that's great. So here you target the saturation level irrespective of the gestation days. You target the saturation. So I think in this particular case, like in 28 weeker, you generally start with 21 to 30%. So generally we start with 30%. And if the child is achieving the saturation as per your minute specific target saturation, you gradually decrease with a percentage of 5. How fast you should decrease, there is no clear guideline, but we don't want to have very high saturation. We all know that we want to keep it below 95%. That's true.
So thank you, Dr. Ankur. Just two questions actually. Dr. Rajendra Prasad already answered, but in the chat box. But still, I will, for the all larger audience sake, I will ask the same question. Repeat. One question came from regarding the temperature on the warmer care. If you use a servo control, twice question came actually. If you were using a baby on servo control, you fixed at 36.5 or 36.7. The servo control job is to get the body temperature, skin temperature 36.5 by increasing or decreasing the radiant heater output. Still, why to cover with a cloth? That's one part of the question. Second part of the question, as we know, the incubator can give a humidity, fixed humidity, 40% to 95% humidity, or 100% humidity also we can put it there. But a warmer, which is open care system, can it provide a humidity, which Dr. Mehak presented 60% kept in 50% humidity. So these two probably can clarify people's doubt actually. Any of our faculties, any of our moderator or Dr. Mehak only can take the question, can answer. So if you are seeing in a warmer, can we fix the humidity? Or second, should we cover with a cloth when already a servo control machine is in use?
Sir, ideally it should not be covered because the skin temperature has to be monitored, is to be taken care of. That is to be kept in mind in servo controlled mode especially. And also regarding what was the second question, sir? The second part of the question?
You don't want to cover with cloth, or you don't want to cover with any plastic wrap, also transparent plastic wrap to create a microenvironment. Do you want to use it or not? This is both the questions.
That we do in ELBW babies to prevent the insensible water losses, sir. That is, in preterm babies, the insensible water losses account around 80 ml per kg per day. So that's quite a lot. So we do want to prevent it. In certain centers, we even keep the baby in incubators. Here we keeping under the radiant warmer. So we aim at that only, sir, via the cling film wrap.
So the basic fundamental to conserve the heat and decrease by the convection currents. So that is the basic thing, the why you use the cling wrap basically.
Cling wrap microenvironment, many way it helps also because unintentional. When intentional, we are going to examine the baby, that's fine. People in the surrounding unintentionally, they touch the baby, they hold the baby. So that also can be prevented by creating a microenvironment. Your temperature care and unnecessary touch also you can avoid to the baby. That's two thing advantage of Tingra. But another question came, humidity. Can we fix humidity in the warmer? Incubator, we know there is humidity option is there. Can we open warmer? Can we fix the humidity? Is there an option to give humidity?
No,
I
the
think
question.
there is some jugaad you cannot do. So what people have suggested that in the micro environment, when we're putting the baby and covering with cling wrap, you can use a sterile bowel and keep a full half bowl of water in there. Probably they would create some amount of humidity. You don't know how much humidity. If the baby is getting some amount of humidity, it is better than nothing.
I would have little bit issue with that, because the risk of Pseudomonas infection will increase with that if you don't change the bowel or you put a glacial acetic acid, something on that. I would suggest to maintain a humidity of the nursery
NICU.
rather than NICU rather than of this, until unless you have a good incubator of a good company where you can maintain a humidity. When I was doing AIMS, I still remember we had a blast of Pseudomonas infection just because the humidity was maintained inside the incubator and the chamber, humidifier chamber was not changed. I remember that was Drager incubator. So we had a blast, means we lost 3 babies continuously at that time. And we could, it means the reason is always the water. So we changed the water and we stopped using the incubator for some time. And after at least 1 to 2 weeks, we could actually handle that issue.
I think that's a very important thing. I think just, yeah, and Nalini, please go ahead.
Please go ahead. What I'm saying, I'm giving a message here to all the training and audience. Humidification of the warming system is a convection current center. The mechanism depends on that. So we should close the environment of incubator. We can provide humidity. And when it open system, probably humidity we cannot ideally provide, and we should not try also. It is a radiation system there. So there probably it's open system. So a micro environment, anticipating some of the humidity will be there from the environment, but it is difficult to quantify. The way the presentation somebody queried, 60% humidity we kept. That's probably created a little confusion.
I think she told 60% of the room, the environment. She didn't tell about
Nico.
That's okay. Environmental, okay. That I'm saying, anticipating of some from the environment, not difficult to quantify in the surrounding to the baby. But in incubator, we can choose fixed. That's to clarify actually to the audience. Okay. So next question, a very important question, Dr. Rajendra Prasad pointed out and during presentation asked actually to Mehak. So what I'm asking now to clarify, for the regarding the practice of humidification chamber, which setup, because questions came also. Should we go for an non-invasive setup? Should we go for an invasive setup? If there is a servo control, how much temperature we should target? If there is a manual setting, how much temperature we set it? So we need clarification for the learners when we are talking about practice of humidification.
Very important aspect. So for invasive ventilation, it is very clear. We have to choose the invasive. And for non-invasive ventilation, for children more than 1 month, people always choose the non-invasive mode. But in neonates, actually, there is a concern that so when we choose non-invasive mode, the air is delivered to the nostril at 34 degrees. And we assume that the baby's, whatever the nasal, the airway, upper airway, is going to bring it to the room temperature, sorry, not room temperature, the body temperature, which is 37 degrees. But when we talk about preterm babies, this may not happen. So that is the reason why many units, actually, they are now using invasive mode even for the non-invasive ventilation. So even at the nasal level, they are delivering a temperature of 37 degrees. So that the baby's, whatever the short and immature upper airway, it won't be strained. And the lungs will not receive the colder air. So I think there were some studies also going on comparing this 37 degree versus 34 degree for babies on non-invasive ventilation. I'm not sure if any of those was published or not, but there is some still dilemma in this.
In the manual, the product manual, Fisher-Packard manual also, the standard which we use, it was their non-invasive recommendation few years back, and they changed to invasive mode. So across the HFNC more than 2 liter, HFNC more than 2 liter, CPAP, NIV mode, standard invasive ventilation, HFO with nitric system, all across now the mode is invasive mode. Target is 36.5 to 37.5. That's the standard and easy to remember. If below 2 liters somebody is using the flow, they may discuss differently. Above 2 liter flow, across all the devices, machines, The standard mode now is the invasive mode, which target is 36.5 to 36.5. Only one caveat here. If we are using non-invasive mode, but using the invasive mode of humidification, there is excessive misting, excessive humidification in
This
respiratory
happens.
chamber. Some of the people observe. So you have to clean little more frequently. That's few times observed. They raised the issue. Non-invasive mode, is it going to dampen the flow? That's the real question. Now, practical questions people are asking. For that reason, the design of the study that a non-invasive mode is better invasive mode. Otherwise, temperature-wise, if a higher flow, 36.5, the probably reasonable is good practice.
Yes.
So anything practice-wise, any questions? Dr. Rajendra answering, but only these questions are not visible to the audience. The questions will come to your answers again. Only we can see as a faculty.
Oh,
I think
these
there are two presenter, I think Mehak and Monica. So I think questions can be asked to the other presenter also, because she is also.
Yeah, absolutely. Dr. Monica, she has done a good job. All the protocols she presented. So here I will ask a question. In babies less than 32 weeks with retraction, CPAP is better in babies more than 32 weeks till 36 weeks. That's a little confusing question.
Yeah.
I will say 32 week retraction is there. Dr. Monica, you will prefer CPAP or HFNC? That's the question.
So we actually prefer in less than 32 weeks, we prefer a non-invasive ventilation as compared to CPAP, because there are more evidence that there are lesser chances of failure and there is less need of intubation further. So we prefer NIV over CPAP in less than 32 weeks.
So I will tell this, sir, like less than 32 weeks.
Right person.
Yeah,
Dr.
less than
Rajendra
32 weeks.
Because he has written a review article with Dr. Murki. I quoted in the previous session. If you in this baby is larger to smaller, sicker to stable, these babies are spectrum there. According to the spectrum, they have written a review article. I have referred that IJP article to all the students to go through to get an understanding where to HFNC, where to CPAP, where to NIV. But Dr. Rajendra today is himself available. He can clarify a little better.
So for less than 32 weeks, definitely we are going to use the CPAP or NIV, which is preferred to HFNC. Between 32 to 36 weeks, I will tell it is based on the risk of having underlying lung problem. Like basically the risk of having either RDS or the risk of having congenital pneumonia. If you feel your child, like mother has chorioamnitis or the baby, there was no antenatal steroid course, then it is better to go towards CPAP. And if the distress is more, suppose the Silverman Andrews score is more than 3 or 4, then obviously we will start with CPAP. If it is mild retractions with no much FiO2 requirement, you can consider doing HFNC in a baby who is more than 1.5 kg. But smaller babies, more at risk of RDS, more at risk of pneumonia, better to choose CPAP.
I think true. I think the message should be clear that the high flow probably is a step down, and probably the failure rate is around 28 to 30%. I mean, irrespective of the countries.
If you are considering RDS diagnosis, there is no role of HFNC.
Don't waste your time using high flow. It's better either CPAP or NIV, depending on your unit policy.
So another quick question, very practical question asked by somebody. So I will ask here again, repeat. So traditionally we learn before weaning the PWP, wean FiO2, keep the FiO2 low, and then wean the PWP. That's the traditional teaching. So anybody take the question, Dr. Monica, or that later some of the faculty can explain. But I'm giving a typical example. The CPAP is 8 and FiO2 is 30. What do you want to wean? FiO2 to wean, or the CPAP you're sitting at 8 you want to wean? Traditional teaching, wean FiO2 to the minimal and then go for the PWP. But I'm sitting at 8 CPAP. How will proceed? What practical tips we should apply?
So like if we are weaning FiO2 like from 50% to 40 and then 30, we can simultaneously decrease the PEEP. If we are decreasing, we can aim for reduction of CPAP. We are decreasing 10% of FiO2, we can decrease a PEEP of 1 centimeter lower simultaneously, rather than just waiting for at least FiO2 of 30%, then decreasing the PEEP.
Perfect, fine. Your message is very clear. Parallelly, you have to decrease both the things, but one of the faculty can give your inputs depending on disease how to deal, because the way the ARDS trial, there is a PWP FiO2 chart is there. In preterm newborn, there is no FiO2 CPAP chart. So clinically, judgment how to proceed, a student how bedside will proceed, any of the faculties can give a guidance. But you're perfectly right. Dr. Monica. I agree with you.
So I will try to explain this. Basically, the titration of PEEP is primarily based on the respiratory distress, the tachypnea, retractions, and the titration of FiO2 is based on the saturation targets. It has to be between 91 to 95. But as Dr. Monica was also pointing out, usually you taper both of them parallelly, and they should go hand in hand. Suppose you are tapering, you are able to taper PEEP. Suppose your retractions are not much, and you are able to come down from 6 PEEP to 5 PEEP, and FiO2 is not coming down. Then you have to think: is there any other alternative diagnosis in that way? Usually they go hand in hand. Usually at 5 PEEP they require less than 30%. At 6 PEEP it should be less than 40%. At 7 PEEP less than 50%. So if they are not going hand in hand, then we have to reassess, reconsider our diagnosis, underlying diagnosis.
I think just want to add, I think slightly on the larger baby, I think we all were talking about the preterm babies where RDS and the atelectasis is a concern. There are one group of baby where there would be a disproportionate oxygen requirement comparing the PEEP requirement, where that means there is no atelectasis, could be PH or moderate to severe PH, pulmonary arterial hypertension, they would require higher FiO2 comparing the PEEP. So in that setting, probably you need a lower PEEP. Obviously, you have already done an X-ray and you are already looking at the FRC that is already fine with a PEEP of 5 centimeter, but they would be requiring a FiO2 of 50 or 40% sometimes, probably in larger group of it. Otherwise, entirely correct, Rajendra, what the message is very
Typically
clear.
in RDS they go hand in hand.
Yeah, so
should not be
yes,
much
hand in hand. Yeah,
divergence
so
between.
yes, true. I think great.
Quick one question.
Yeah.
Presentation went to RDS CPAP. I will ask a quick question. If a meconium aspiration baby came, can we start CPAP, and what CPAP setting you will choose? Because it's not covered here, but the audience maybe will be interested CPAP to start in meconium aspiration. If I want to start, how much to go ahead? Then this is the question, clinical questions. Any of the faculties, Dr. Kamaldeep or Dr. Rajendra, Dr. Ankur can take and guide the students. If it's meconium aspiration.
One thing
Dr.
I
Ankur,
want to say. Yeah, please, Kamal, go ahead, please.
Dr. Mac, can you answer this question? I would like to ask from Dr. Mac because we
Yeah,
discussed.
please, Mac, go ahead. Yeah, I think Mac and Monica should answer this question.
Mac, are you there?
So the preferred, yes, sir. Yes. Can you hear me?
Yes.
Both you can answer. No?
So the chosen
One by one.
The chosen indications for CPAP institution are RDS, mostly apnea of prematurity, since it causes the splinting of the upper airways. Then the third reason could be post-op, we put the babies onto CPAP. Fourth is delayed adaptation, for example, TTNB. But the relative indications, meconium aspiration is one, but CPAP institution in a baby with meconium aspiration syndrome can be a little tricky, because in meconium aspiration syndrome, we have certain areas wherein there is over distension of the alveoli because of the ball valve effect, as the meconium is probably placed in the airways, while certain areas can have atelectatic alveoli wherein they are completely collapsed. So if you're giving CPAP, it is going to cause institution of a continuous airway pressure in a spontaneously breathing baby. So it might lead to air leaks or pneumothorax in babies with meconium aspiration. So, but we can, trial can be given in cases of mild.
So what would be your preferred modality for this baby?
So if the baby is very sick, then we prefer to intubate this baby if the baby is hemodynamically unstable. But if there is only mild RDS with only mild respiratory distress and the baby looks otherwise well, then we can give a trial of HFNC for this baby.
Okay. So what is the answer from Dr. Minglani? The other...
Monica.
Sorry.
Dr. Monica, what's your take?
Yes. So as I have shown the indication of CPAP, that in either in a case of term more than 35 weeks, if baby is having respiratory distress with silver Andaman score more than 5 or equal to 5, we can give a trial of CPAP, whether it's a case of a meconium aspiration syndrome as well. So depending on the work of breathing and retractions, and by continuously monitoring, we can look for air leak syndrome. So, but as a first support, we can start CPAP in meconium aspiration syndrome.
Okay, so let me give that answer. What we do in our unit is, it is actually very tricky to give CPAP in a meconium baby. One major thing is that baby is a large baby. They don't tolerate CPAP. The other issue is what Mahak told, that it's areas of atelectasis and areas of hyperextension. Pneumothorax goes very common with these babies. So we in our unit have a policy that we don't start CPAP. We start with HFNC in these babies for a mild RDS, or sorry, mild meconium aspiration syndrome. For a severe, we ventilate the babies to prevent any PPHN. Dr. Ankur.
I think my answer is for the resident. So you treat the patient during the first golden hour depending on the respiratory distress, irrespective of the clinical conditions. You start your treatment depending on your scoring. Maybe you are scoring for the atelectasis, and that is by the retractions, and you do some scoring like Silverman-Anderson scores. So basically, there are two types of disease. It's for the resident mainly. So there are two types of disease. One is restrictive lung disease and one is obstructive. And they are a group of disease. They can be both restrictive and obstructive. And specifically meconium aspiration syndrome, they have a spectrum of disease. And the majority of the meconium aspiration syndrome, so-called misnomer meconium aspiration syndrome, they would present like maybe TTNB simple. They can present like an atelectasis, and they would require oxygen. They can present like atelectasis along with some airway blockage, and there are certain conditions they would require they would lead to PAH. So in most of the scenario in our unit, irrespective of the diagnosis, we treat the patients with a CPAP. Yes, there is a limit. We generally say that we won't increase the PEEP up to 7 centimeter. Beyond 7 centimeter, we don't use. We will have a low threshold for giving surfactant. In this case, if the F2 requirement is more than 40%. So I think we generally start with CPAP. I think unit to unit policy can be different. This is the usual policy in that. And during the first hour of management of all the disease, you don't go for the diagnosis of disease. You treat clinically. That is the aim of the. Annalini and Dr. Rajendra, you can give your opinion.
I agree with that.
We use in RDS meconium aspiration, we initiate to prevent for further ventilation, for the surfactant we reduce. But it is not like typical like a preterm RDS. So more careful monitoring.
Yes.
Because and there's a hypoxic component. If born with a HI or hypoxic component, little tricky. It makes little tricky. With a cardiac decompensation, it is more tricky.
Yeah, that's entirely different.
Pneumonitis, little RDS, and with low compliance, resistance disease, we know low compliance is also must be there. In that case, many of the babies rescued by few hours of CPAP, not going to PPH, not going to intubation, not requiring surfactant later. That's my take. We start it, but be more careful for a baby. That's the way I will see. We have saved probably, not published many, but we have saved so many probably babies from ending into treating PPH and giving surfactant later by just starting CPAP. And popular belief, meconium aspiration use low CPAP, 4 CPAP, 3 CPAP. No use 5 CPAP. And standard, if the evidence, you were discussing about evidence, they are more successful using 6 CPAP rather than 5 CPAP. But practically, I will say use 5 according to F2 and take the call accordingly. So that's the evidence, whatever published Western evidences also.
I think I don't remember from the studies were done intubations versus giving CPAP. They don't found any increase in the pneumothorax risk. That's how I think most of us are, giving a fair trial of CPAP even in cases of MAS also.
Yeah, I agree with what you are telling. The distress is mild, like Downey score is less than or equal to 3, we can start HFNC. But if the distress is more, definitely we can use CPAP. And when we are using CPAP, generally we don't cross PEEP of 6. Exactly because of the risk of air trapping and air leak. And if the X-ray suggests some mild air leak, then better to change CPAP to HFNC.
True, agree.
Perfect.
I think it's a
long good discussion happening today, and presentation was awesome today. So, but quickly, just one point I will for the audience sake, one questions, one practice. Dr. Monica and Dr. Mahek, I will ask. You are taking care of CPAP baby. You saw that many of the interface use CPAP injury is many times long CPAP use, eminent injuries sometimes we see. How will optimize the care to prevent the CPAP injury? Dr. Monica, just quick one practice points I will ask now to both the presenter. They have done a great work, great presentation. One question from you. Dr. Monica, how to prevent the injury, CPAP injury?
So we have to continuously monitor the patient every 1 hourly, from starting from the patient vitals to the machine and the interface as well. So for nasal interface injury, we can look for the appropriate size cap and appropriate size mask and prongs, and maintaining the gap between the mask from the prongs and columella to prevent the nasal septal injury. So and look for the any nasal obstruction or secretions to clear so that adequate PEEP can be delivered. So
So any
we
occlusive,
can 1 hourly monitor. We can use tegaderm and occlusive drape to prevent skin injury and nasal injury also, sir.
and humidity should be adequate again. Unless
Yes.
humidity is adequate, again dry.
Question is the
Yes, sir. Yes, sir. We have to set the temperature of humidifier 37 degrees Celsius so that to prevent the mucosa damage or which further leading to the mucociliary clearance ineffective. So maintain humidity as well as.
All things
So
should be right.
first of injury, that is rhythm, you have to take care of that part. Don't let it happen to an injury beyond rhythm. So if the redness is happening, please take care at that point only. Don't think this is just due to the pressure. This is also an injury. It may be a grade 1 injury, but it's an injury.
So for injury monitoring, shift wise, we can put a chart in the CPAP bedside. If each shift, somebody can note it down, what's the level of injury. In the initial stage only, you can stop it. So next question, I will come to Dr. Mehak quickly. If CPAP belly you are seeing, you are using CPAP, getting CPAP belly, how to prevent it, how to address it, because people are worried. Now people, CPAP belly, stop feeding quickly. They see the bedside CPAP belly, absolutely stop feeding, but should not be done. So how to prevent it, how you will optimize to get less CPAP belly?
Very important.
Right, so CPAP belly is actually a very common problem that we see with CPAP institution in these small babies. So number one, for the monitoring, abdominal girth monitoring has to be done for these babies on CPAP, and we do put a chart in the nursing care bundle also, wherein regular abdominal girth monitoring has to be done. The other thing is that the feeding tube, which is placed in situ for the babies on CPAP, should be open. And so that any excess air that is there, because the air is also entering into the esophagus, that is coming, that is ejected out of the open end of the feeding tube.
So any opinion, faculty's opinion here? How
Yeah,
to...
two things we have to take care. One is the flow. The flow should not be excess. If the flow is excess, there will be CPAP belly. And second, we have to keep the nasogastric tube open. Usually what most people do is they give feed, close it for 15-20 minutes. The gastric emptying time is usually 20 to 30 minutes. After that, you can keep it open. There are many jugaad ways of keeping it open. Some people hang some plaster from above and stick to it. Or you can just put in a cover. Anyways, you can do that, but it is important to keep it open. And most importantly, any baby requiring non-invasive ventilation should have a orogastric tube. Sometimes we see babies who are transported without orogastric tube and on CPAP. That is very dangerous.
So thank you for clarifying many things. Staying late, actually 9:45. So
Yeah,
we cannot
it's
go to-
9:45, I think.
Yeah.
Kamal had
Yes.
Kamal had already had dinner. I think that's why he's happy, smiling.
Yeah, my dinner was a salad and just a cup of coffee. So I'm very happy with that.
Thanking all the faculties, moderator. I just will now just request one message from 3 of the faculties. Then we'll close the session for the learning. One message from each one. One message. We'll close the session. And today we can end the session after message.
I think let's start from me. I think use CPAP right from the delivery room and optimize CPAP depending on the clinical condition. That is very important. Just don't fix at one number.
Dr. Rajendra.
Yeah, I think we should give the right mode for the right baby. Maybe your initial mode can be NIPPV, CPAP, invasive ventilation, or HFNC, but we have to choose it appropriately. So just starting is not enough. We have to meticulously monitor the baby. We may have to escalate the support, de-escalate the support, or we have to continue the support. Everything will be based on the continuous monitoring. And we should always try to make a diagnosis of the underlying condition and give targeted therapy.
Okay, sir. So my main point is that whenever you start a CPAP, the first indication for that is the baby should be spontaneously breathing. Don't put on a baby who is apneic. should not be put on that. Baby should spontaneously breathing. I think everybody knows that point. One second, what Dr. Jinder said, the same thing. The monitoring is the key. Don't think the baby is on a CPAP and the baby will not deteriorate. The baby can deteriorate. It can be complication of the CPAP itself. The pneumothorax can happen. The complication like the CPAP delivery may not happen. So meticulous monitoring is the key. The third point is, see, we have seen the support trials, the coin trials for all those trials that these babies may require a surfactant. So the babies who are premature, like this baby who was a premature, didn't give, was surfactant was not given, less than 28 weeks. The steroids were not given. So these babies required surfactant. Don't think that if you put a baby on CPAP, the surfactant requirement not be there. So 50% of the babies may still require the surfactant. So you should know the criteria for giving that surfactant. The baby is premature, steroids not given, or severe birth asphyxia, or RH isomanation. The criteria or the protocol for the your unit should be very, very clear with that point. Otherwise, in the morning, you will end up with a baby who has atelectotraumas and nothing will happen. So CPAP is a good modality, but monitoring is the key.
Absolutely. We agree with all the messages, very clear. The final message, I will say, less is more in neonatology. So whenever opportunity use CPAP, so less is more. We don't want to neglect. But again, when we are using CPAP, it is not a spontaneously breathing baby. Is a form of positive pressure ventilation. So be careful, monitor, prevent the adverse effects. And when you're using it, my last message is don't ignore the oxygen level. With CPAP, if we are ignoring oxygen level, without unlimited oxygen we are supplying, probably we are generating high PO2 and eye injury, brain injury follows. So strictly follow the guideline of 90 to 95 saturation when babies on CPAP. That's a few messages. Thanking you all the faculties, all the students. The good work should continue, and you presented well. And from you, probably the next batch should learn how to present briefly and covering all the points. Thanking you all. I'm closing the session. Thank you all again.
Thank you. Thank you, dear. Thanks.
It was actually a wonderful session and very good moderation done by you. You kept on till long, and I think everybody was awake till that time. And thank you, Dr. Jinder, for the same.
Thank you. Thank you.
Thank you.